This presentation is on sialorrhea, salivary incontinence, drooling, and hypersalivation. The references list for this presentation and the suggested readings include 4 different publications from NICE, the National Institute of Clinical Excellence, including guidelines on the management of drooling in cerebral palsy in children and young adolescents, another one on the treatment of drooling and Parkinson's disease in the adults, a third one on the use of anticholinergic medications, and a fourth on the use of botulinum injection. There is also the National Health Service Integrated Patient Pathway for Chronic Sialorrhea in adults, and several meta-analyses, including one meta-analysis on the use of Botox injection and another on a meta-analysis on the results of surgical interventions for drooling. Drooling is salivary incontinence. It's the involuntary spillage of saliva over the lower lips. When the saliva overflows outside the mouth, it's anterior drooling, and it's by far the commonest way these patients present. But the possibility of posterior drooling when saliva leaks from the back of the mouth into the pharynx should not be ignored, because this is an aspiration risk and should be checked for in every patient. Normally, most children would drool until the age of 15 to 18 months. They grow out of it by the age of 2 years. But if they continue to drool after the age of 4 years, then they will need some form of help or intervention. Drooling can be caused by excessive production of saliva, or the inability to retain the saliva in the mouth, or problems with swallowing. The overproduction of saliva, the hypersalivation, is actually extremely unusual. Most patients with drooling would have problems or difficulties in salivary control rather than in true hypersalivation. Untreated drooling can have several effects. Perioral maceration of the skin and cracking of the skin, and this can be secondary infected, can also have various dental problems, and these can lead to foul breath. The drooling can also indicate a risk of aspiration through posterior drooling, can cause a degree of dehydration. It interferes with speech and with normal swallowing, and can have various psychological effects, including the difficulty in social interaction, can lead to isolation and decreased self-esteem. Anterior drooling is far commoner than posterior drooling. They can happen independently, so a patient can have either anterior or a posterior or a combined anterior and posterior drooling. There are several indicators that posterior drooling is happening. These include repeated episodes of pneumonia, repeated antibiotic courses for chest problems, evidence of chronic respiratory lung disease, and should be checked formally in every patient by fibro-optic endoscopic evaluation of the swallowing, assessment by fees. The normal salivary production per day is anything between a liter and a liter and a half. And 90% of this amount will be produced by the major salivary glands. In the unstimulated, the resting state of the salivary glands, the rate of production of saliva is between 0.02 to 2.75 milliliters per minute. And this is important to give us the sense of moisture in the oral cavity and prevents the dryness and xerostomia. 70% of the saliva in the resting state is produced by the submandibular gland, with some contribution from the sublingual gland. When the salivary production is stimulated by meals or before meals, the salivary production is increased 5 times. The rate of production per minute is increased 5 times. And most of this extra production will come from the lid gland. The excess saliva in the mouth will be swallowed, and normally this swallowing rate would be once every minute during awakening. It's important reflex to clear out the oral cavity from excess fluid. A normal adult would probably swallow just less than 600 times in a day to clear excess saliva. Salivary production is controlled by the autonomic nervous system with both components, the parasympathetic and the sympathetic components. These are in turn under control of higher centers and can be stimulated by things like vision, thoughts, smell, or taste of food. The parasympathetic fibers originate from the midbrain, from the pons and the medulla through two centers, the superior and the inferior salivatory centers. And then they pass from the superior salivatory center through the facial nerve to the coda tympani nerve to the submandibular ganglion, and then to the submandibular and the sublingual glands, or from the inferior salivatory nuclei to the ninth cranial nerve, to the promontory, to the optic ganglion, and then through the auriculotemporal nerve to the parotid gland. And these form the basis for surgical intervention to treat excess saliva production and drooling. Various physiological causes of hypersalivation includes teething, pregnancy, nausea, ingestion of food. Certain amount of foods like sour or spicy food would lead to hypersalivation, and certain emotional conditions can also affect the salivation through the salivatory nuclei, including pleasurable sensation or anticipation of pain that can increase the production, or fear that can decrease the production of saliva. The less common presentation of sialorrhea by acute presentation can be caused by infections in the mouth or the throat, some viral infections, dental problems, pain or abscess collection in the peritonsillar area, epiglottitis, damage to the oral or pharyngeal mucosa by caustics or direct trauma. Stroke can cause acute sialorrhea, and several medications, including toxins exposure, can also lead to acute presentation with sialorrhea. Chronic sialorrhea is the commoner of the two presentations, and it's also much more challenging in management in terms of assessment and treatment. They can be either caused by systemic causes or local causes affecting the oral cavity and the oropharynx. The systemic causes include things like cerebral palsy, where almost half of the patients may drool, motor neuron damage, cerebrovascular accidents, like, for example, stroke, Parkinsonism, where just less than half of the patients may drool, congenital malformations, myasthenia gravis, and learning disabilities. Also, toxin exposure, including exposure to pesticides, mercury, selenium, or lithium, and several medications acting on the central nervous system like tranquilizers and anticonvulsants. Also medications affecting the parasympathetic nerve supplies, and morphine and cocaine. The local causes include major resection of the oral cavity or the oropharynx, for example, the Andy Gump deformity, malocclusion, gastroesophageal reflux, in control of the head posture or the sitting position, and constant open mouth, poor lip control, hypoactive gag reflex, nasal obstruction, macroglossia, reduced tongue thrust, and facial nerve palsy. Assessment is best carried out by a multidisciplinary team with input from both the patients and their carers, and should cover four areas: the cause of the chronic drooling, the oromotor assessment, any complications, and how severe is the drooling. The cause would include reviewing a list of all the medications taken by the patient, neurological and psychological assessment by specialists, dental and orthodontic assessment, and ENT evaluation by endoscopy for the upper air digestive tract and functional assessment of the swallowing and whether there is any gastroesophageal reflux or not. Moving to oromotor assessment for the head control and positioning of the patient, the mouth closure, the lip seal, the occlusion, and the swallowing reflex, together with sensory motor examination. And then we move to whether there is any associated complications like aspiration, weight loss, dehydration, malnutrition, and then assessment of the severity of the drooling by various tools. These are the common and the simple tools to quantify drooling. It includes methods to quantify the severity and the frequency of the drooling, and also a method to assess the response to certain treatment or intervention. The drooling rating scale evaluates the severity and the frequency of the drooling. Also, the modified teacher's drooling scale covers these two areas, the severity and the frequency of the drooling. You can just simply measure how many napkins have been changed daily for the child, and this is the basis for the bib diary, and the drooling impact scale, which evaluates the effect of intervention on the salivary control after various forms of treatment. The first quantification tool is the drooling rating scale, and it covers two areas, the severity and the frequency of the droolings. The severity is assessed by a 1 to 5 point scale, where 1 is never drools, 2 is mild with wet lips only. When it is wet lips and chins, it's 3. When the clothes also becomes wet, it's 4. When it's the clothing, the hands, the tray, and other objects are wet, then it is 5, or profuse drooling. The frequency of the drooling is measured on a 1 to 4 scale, where 1 is never, 2 is occasionally drools, 3 is frequently drools, and 4 is constantly drools. The second tool, the modified teacher's drooling scale, is a combination of the two areas, the frequency and the severity of the drooling, into one system, where 1 is never drools, 2 and 3 are mild drooling, and making only the lips wet, either occasionally or frequently. 4 and 5 is moderate drooling, wetting the lips and the chins, either occasionally or frequently. 6 and 7 is severe drooling, wetting the clothes, again either occasionally or frequently. And 8 and 9 are profuse drooling, wetting the clothes, the hands, the trays, and objects around, either occasionally or frequently. There are several other ways of quantification of drooling, including things like visual analog scales between 1 and 10 to try and quantify the severity and the frequency of the drooling, counting the number of standard sized paper handkerchiefs used per day, measuring of the saliva by collecting it in cups strapped to the chin of the patient, or inserting pieces of dry gauze in the mouth for a specific period of time and then waiting it again. And there are the more technical ways used for quantification of saliva, like salivary gland scintigraphy or technetium scanning, and salivary duct cannulation and collection of saliva in cups. We move now to the management of drooling, and these cover 4 areas that are not necessarily mutually exclusive. These 4 areas are either conservative or trying to reverse some causes, specific oral motor exercises and appliances, medical ways, or surgical interventions. It's important to know that no single approach is totally effective in the treatment, and the management usually entails a combination of these techniques. This is the first step in the management, the correction of the reversible causes and some conservative measures as well. It starts by checking the medications list and eliminating any possible source for hypersecretion of saliva. Then checking the dental problems or malocclusion. Occasionally, adenotonsillectomy may be helpful in relieving obstruction at the nasopharyngeal or the oropharyngeal level. Postural control of the head, neck, and trunk should be improved. And then simple advice like dabbing rather than wiping across the mouth and the chin to decrease the irritation, prevention of excessive mouthing of the fingers or other objects, and adjusting the diets to eliminate things like fizzy drinks, acidic food, spicy food, and of course alcohol. The earlier the speech therapy is started, the better the results are. These should cover areas like exercises and training for improving head position and jaw stability, increasing the tongue mobility and strength and positioning, improving lip closure, particularly during swallowing, decreasing nasal regurgitation exercises, and playful exercises to improve anterior lip seal, like pronouncing M sounds, or sucking and blowing exercises and games using straws and candles. And then there's another group of exercises and training designed specifically to improve the swallowing reflex or the salivary control. They are called the oral facial facilitation techniques. These are groups of techniques that may improve the sensory, the motor, and the central part of the swallowing and the salivary control reflexes. They include any of these five techniques that can be tried before meals because the effect of these techniques last only for about 30 minutes or so. They include swallowing things like crushed ice, brushing of the teeth of the lips or any parts of the oral cavity, applying vibration to increase the muscle tones, manipulation of muscles by tapping, stroking, or petting. Firm pressure applied over muscles can also improve its tone temporarily, and oral motor sensory exercises to improve lip closure and tongue exercises. Most studies show that these techniques can give only short-term benefit with little benefit in the long term. Some extra help can be obtained from functional appliances. They include different types of appliances designed to either stimulate better the lip or the tongue control or to help in preventing spillage of saliva anteriorly. They include things like the stimulating palatal plate, which helps in preventing the thrust of the tongue forward and thereby improves the posterior and upward thrust of the tongue base, improve in swallowing of excess saliva, things like acrylic bumpers, which also helps in obtaining a better lip seal and also stimulate the lip and other oral segments movements, and things like the mouth vestibular brace, which has flanges both to the buccal side and the labial side. They both stimulate the muscles of the lip to effect a better complete closure. Conservative management can be helpful in a selected group of patients, but usually some other forms of therapy must be added, and these include medications. We start with this group of medications, the anticholinergic medications. The secretion of saliva is under the control of the parasympathetic autonomic nervous system, and the acetylcholine works as the neurotransmitter for the secretion of the saliva. So inhibiting the action of acetylcholine at the muscarinic receptors can reduce the production of saliva. The main problem with this group of drugs is the severe side effects, particularly cognitive function effects in patients who have neurological problems like Parkinson's disease or cerebral palsy. So it's usually these drugs are started at a fairly low dose initially, and then titrated up to obtain a therapeutic effect and titrated down if side effects are recorded. The main problem of the anticholinergic drugs is their tolerance, their side effects, and that's why they can be contraindicated in some patients. They are generally poorly tolerated in the elderly patients who have several comorbidities. The side effects are numerous and include things like dry mouth, drowsiness, blurring of vision, tachycardia, arrhythmia, flushing, constipation, urinary retention, vomiting, nasal congestion, headaches, decreased sweating, dizziness, and various other things. The anticholinergic drugs are contraindicated if the patients have glaucoma, obstructive uropathy, gastrointestinal motility disorders, or myasthenia gravis. The number one drug in the anticholinergic medications group is the glycopyrronium bromide. This is the drug recommended by NICE for the use in children and adolescents, and also in the use for Parkinson's disease. It has less side effects than other anticholinergic drugs, and less tachycardia, for example, and less drowsiness and other CNS manifestations because of its fairly limited ability to cross the blood-brain barrier. It can be expected to achieve some improvement in the drooling in anywhere between 70 and 90% of patients who have chronic drooling. But unfortunately, about a third of these patients will have to stop the medication because of the side effects, including xerostomia, urinary retention, decreased sweating, skin flushing, irritability, and other behavioral changes. Like other anticholinergic medications, glycopyrronium bromide initial dosage should be low at somewhere around 12.8 micrograms kilogram body weight. It should be given 3 times a day, and titration should happen every 7 days or so, up to increase the pharmacological efficiency of the medication or down to reduce side effects. The dosage can be increased up to 5 times the initial dose. The maximum would be 64 micrograms kilogram body weight. The dosage should be given 1 hour before meals or 2 hours after meals 3 times a day. It's important that the dose is given at consistent times in the day and that it should not be taken with high-fat foods. The number 2 anticholinergic medication is the hyoscine patches. These patches work transdermally. They have the advantage of being easy to administer, like you apply a patch only every 3 days or so, and they can maintain a steady state of concentration in the serum with lower incidence of side effects. The hyoscine patches can sometimes cause allergic skin reactions at the site of use, and they have also the other known problems of the anticholinergic medications like xerostomia, dryness of the eyes, visual disturbance, and if used continuously, they tend to lose their benefit with time. One patch is normally placed behind the ear, where it can be observed for about every 3 days or so. Hyoscine hydrobromide patch with a surface area of 2.5 centimeters square would deliver 1.5 milligrams of hyoscine bromide. A stable serum concentration can be expected for 3 days. If a lower dosage is required, then the patch should be applied partially over a dressing so that only the exposed part of the patch would deliver the reduced dosage required. It's important not to cut into the patch to reduce the dosage because this is going to disrupt its matrix and the transdermal efficacy may then be lost. Typically, the patch would be replaced every 3 days. The best area would be behind the ears so that any reaction of the skin can be easily noticed, and the site of application would change every 3 days to reduce any allergic tendency or reactions of the skin. The dose of 1.5 milligrams is for adults and should be reduced to about 1/4 this for an infant below the age of 2 years, half this for a child less than 9 years old, and 3/4 to 2/3 of the dosage for adolescents between the age of 10 and 17 years. The second line anticholinergic drugs include Trixifinitiel. This is primarily used in patients who have chronic drooling, but also dystonic movement disorders, like children who have dyskinetic cerebral palsy, for example. It acts by inhibiting the acetylcholine release in the basal ganglia, so that would help with the motor control, as well as help in inhibition of excessive drooling. Its use is limited by its troublesome side effects. These include tachycardia, constipation, hallucination, and memory impairment. It should not be used in the elderly. There are several reports on the use of other anticholinergic medications besides the first-line anticholinergics, the glycopyrronium bromide and the transdermal hyoscine hydrobromide, or the second-line anticholinergics, the trihexyphenidyl. There are reports on the use of amitriptyline at a low dose of 25 milligrams once at night time, and then the dose can be titrated up gradually every week or so, up to a maximum of 100 milligrams at night time. There are also reports on the use of atropine, 1% eye drops, but this time used as 1 to 2 drops sublingually in the morning, and the dose can be increased gradually, 1 drop every 2 days or so, up to a maximum of 8 drops a day divided on 4 times. There are obvious cost implications for the long-term use of anticholinergic medications in chronic conditions like chronic drooling. For example, the glycopyrronium bromide price is in excess of £600 per month, followed by the treatment of atropine 1% eye drops sublingually, compared to other available medications like the hyoscine patches or the trihexyphenidyl or the amitriptyline. We now move to another line of treatment for chronic sialorrhea, the injections of botulinum toxin. These are available in 4 different forms. 3 of them belong to type A toxin and 1 belongs to type B. Botox, dry spot, and Xeomin belongs to type A botulinum toxin, and Rima botulinum belongs to type B type of toxin. Both type A and type B are effective in the treatment of chronic sialorrhea. There are several reports to back this. They can provide a good reduction in the amount of secretions of saliva and in drooling for a period ranging between 1 and 6 months. The maximum benefit is at a period of 4 to 6 weeks after the injection, but they have side effects including thickening of the secretions, xerostomia, and various injuries to the neurovascular structures within the glands or near to it. Botulinum toxin inhibits the release of acetylcholine in the injected glands, thereby reducing salivary production. This inhibition is temporary because the blockage wears off within 6 months by the formation of new nerve terminals and the resumption of the neural connections. But up to 6 months, 50% of the patients would notice some improvement in the injected glands. Up to 33 weeks, only 25% of the patient may still have some improvement, but after a year, very few patients would notice any improvement at all. The range of the dosage varies widely between the different forms of the injection. The type A toxin in Botox, for example, the dosage is between 10 and 100 units. type A toxin, again in dry spot, is between 20 and 300 units. And for the type B toxin, the dosage is about 2,500 units for the neuro block. The temporary effect of 5 to 6 months would increase markedly in the elderly. The injection technique. The anesthesia used can be either local or a cream applied to the skin, or general anesthesia in some children, when some patients don't require any anesthesia at all. The needle caliber for the injection would vary widely in various reports between 21 and 30 gauge. The salivary gland injected can either be parotid glands only, or possibly also parotid gland and the submandibulars as well. Sometimes this can be done under ultrasound guidance. What is the effect of repeating the injection several times? On the one hand, there are reports to suggest that prolonged denervation of the salivary gland can induce atrophy of the gland itself, so that repeated denervation and injections can lead to a permanent reduction in drooling. On the other hand, there are reports to suggest that the glands lose its responsiveness to the injections after a number of injections and stop to be of any benefit. This particularly refers to botulinum type B toxins. Injection of the botulinum toxin into the parotid glands would reduce the stimulated phase of salivary production, saliva produced during meals, whereas injection of the toxin into the submandibular glands would reduce the resting phase of salivary production and can lead to a sensation of dryness in the mouth and the throat and xerostomia. Combining the injection into both parotids and submandibular glands is reserved for patients who have severely uncontrolled Sialorrhea, or patients who had injection in one pair of the glands only at a time and with no adequate response. The injection in the 4 glands, the combined injection in the parotid and submandibulars, can produce marked decrease in salivary flow and some impairment of oral feeding in children. NICE had supported the use of a certain type A botulinum toxin in chronic Sialorrhea. This is Xeomin, a type A botulinum injection at a dose of 100 units per treatment, divided into 30 units for each parotid and 20 units for each submandibular gland. And the results of the use of botulinum type A in the control of chronic Sialorrhea is supported by various placebo-controlled studies, including the largest study of the type, the SIAXI, which is a prospective randomized double-blind placebo-controlled study and supported the notion that botulinum toxins are effective in the control of Sialorrhea. In addition, a recent meta-analysis had added more evidence to support the use of botulinum toxin in chronic Sialorrhea in children who have cerebral palsy. It showed that the injections are safe, that the injections are effective in controlling the frequency and severity of the drooling. The effect is reversible after a certain amount of time. It lasts for more than 3 months, but usually less than 6 months. The dosage recommended from this meta-analysis was to use 4 units per kilogram of Botox A for the control of chronic Sialorrhea. Definitive, immediate, and long-term control of chronic Sialorrhea may be obtained from surgical interventions. This can be either in the form of salivary duct ligation, either the parotids or the submandibulars, salivary duct diversion or relocation, Again, either the parotid glands duct or the submandibular ducts, or salivary gland excision, this time either the submandibulars plus or minus the sublingual glands, or salivary gland denervation, mainly the parotid and sometimes the submandibular glands. The most common surgical approach is perhaps submandibular duct relocation, sometimes combined with sublingual glands excision. This would entail exposure to the floor of the mouth structures through a rhomboid incision, and followed by identification of the submandibular duct bilaterally together with the submandibular orifice. And then the submandibular duct, when it is freed, together with its orifice and an adjoining piece of mucous membrane, would be fed through a submucosal tunnel to the tonsillar fossa or the anterior tonsil pillar, and then sutured in its new position. This is followed by excision of the sublingual glands bilaterally, and the operation can be expected to reduce saliva production in more than 80% of the patients. The side effects include ranula formation in the floor of the mouth and obstruction of the relocated submandibular duct in about 8% of the patients. The operation, which produces the highest success rate in the control of chronic sialorrhea, is the Wilkie procedure, which entails bilateral parotid duct relocation and submandibular gland excision. The parotid duct is identified and cannulated, and then a small island of mucous membrane around the duct orifice is incised. The freed parotid orifice and duct are then relocated through a submucosal tunnel into the anterior tonsil fossa or the tonsil bed if the patient had previous tonsillectomy. The reports suggest that the success rate is about 89%. Even after 7 years from the operation, the risks of the side effects of the surgery include wound dehiscence, duct stenosis, and septic parotitis. A simpler and a much shorter operation to control chronic sialorrhea was suggested. This is the intraoral ligation of the 4 ducts, the 2 parotid and the 2 submandibular ducts. But unfortunately, the long-term results of these operations were disappointing. Almost 67%, 2/3 of the patients had recurrence of the drooling and required other form of management, either surgery to excise the glands or botulinum injection or anticholinergic medications. The sialorrhea would recur usually at about 4 months after the operation, but sometimes as early as 2 weeks postoperatively. Of interest is that when postoperative objective measures of salivary production, like the technetium-99 scans to the glands whose ducts were ligated, or salivary flow from these glands were measured, in each case there was a demonstrated uptake of the technetium in the glands, or a washout in more than one gland of the 4 glands whose ducts were ligated. Another approach in the surgical management of chronic sialorrhea is the denervation of the salivary glands, mostly through a tympanotomy. Exposure of the middle ear would allow identification and disruption of the tympanic plexus. Tympanic neurectomy would cause the denervation of the parotid gland. Occasionally, this can also be carried out for the coda tympani nerve. The disruption of the coda tympani nerve would cause denervation of the submandibular gland, but also this would lead to a loss of taste sensation ipsilaterally. The operation is short and have few complications, but it provides only temporary control of the sialorrhea, as in most cases the sialorrhea would recur within 6 to 18 months with nerve fibers regeneration. This meta-analysis provided evidence for the efficacy of surgical intervention and the control of chronic sialorrhea. The overall success rates for the surgical interventions was around 80% long-term. The highest success rate was for the Wilkie procedure, closer to 90%, for relocation of both parotid ducts and excision of both salivary glands, followed by relocation of both submandibular ducts and ligation of both parotid ducts. The intraoral operation of four-duct ligation produced the lowest success rate. Bilateral submandibular duct relocation is much complex than bilateral duct ligation, although in some cases the relocated duct gets stenosed and the fibrosis would cause atrophy of the gland, but in such cases at least one of the two relocated ducts would remain patent with a functioning gland behind. Other minimally invasive types of surgery for the control of chronic sialorrhea were suggested, including a denervation procedure for the submandibular glands, but this time much closer to the gland itself, rather than dividing the coda tympani nerve and losing the taste sensation. The gland is denervated by transoral endoscopic submandibular ganglia neurectomy. And another operation was suggested for ligation of the parotid duct, but this time by intraductal laser photocoagulation. And finally, the last line of management of chronic sialorrhea can be radiotherapy. This is rarely used because of the risk of xerostomia, the loss of the taste sensation, and the possibility of development of malignancy or osteoradionecrosis. But sometimes in very highly selected patients, particularly the elderly patients who cannot have surgery and cannot tolerate medications, consideration for the receiving of radiotherapy may be given, a low dose of radiotherapy to the major salivary glands. The side effects include xerostomia, mucositis, dental caries, and possibly osteoradionecrosis. By this, we come to the end of this presentation on sialorrhea, drooling, and hypersalivation. Assalamu alaikum.